And in a lot of cases, people actually live longer with hospice care. In geriatrics, we do stop medicines and they start eating, or we do provide multiple people in the home through the week and they get socialization. They can find a sense of meaning and purpose. You can continue to live while you're on hospice. And so there's ways that we help people do that.
Welcome to In Good Company, Eldercare in Your Backyard, the podcast that brings local perspective on aging, caregiving, and healthcare right to your ears. I'm John Ray.
And I'm Spencer Ernst. Every week, we talk with the people on the front lines, all making elder care accessible to you. Dr. Melissa Gaines is the Director of Hospice and Palliative Care at CoxHealth and Medical Director for its Inpatient Hospice Program. She also practices geriatrics in Springfield, Missouri. With a career spanning patient care, teaching, and leadership, she is dedicated to compassionate end-of-life support. Inspired early on by her mother, a hospice nurse, Dr. Gaines has made it her mission to help families find dignity, comfort, and peace during life's final chapter.
Dr. Gaines, welcome to the podcast. How are you?
Doing good. Yeah.
Wonderful. Well, let me just jump right in. We've got so many questions that are related to hospice and palliative care and the upcoming movie that's getting ready to premiere here in Springfield. Super excited to hear about that. So, but before we get into that, let me ask you what first inspired you to work in hospice and palliative care.
Yeah, and thank you for the invitation. I meant to say that earlier, so I'm thankful that you guys were able to invite me to the podcast. So I grew up with a mom that is an RN. She's a nurse, and she worked in the 1980s when home health started, and then when hospice started, she transitioned to hospice. So I'm very familiar with her leaving the house after dark to take care of patients on call on the weekends. I mean, we were often in the car when she'd have to go see a patient if she was called. And I just, the stories that she would share and conversations that we had just, growing up with her and all of that experience has really kind of inspired me to do this kind of work. And so through training, it just confirmed that I really enjoy geriatrics, and this is definitely part of geriatrics. And so, I think that was probably my biggest inspiration. So
that's awesome. Yeah, everybody kind of has a little bit different path, but having a family member that was directly connected makes that path a lot more direct.
Right.
Okay, so in your own words, how would you define hospice?
Hospice is that care that comes when your illness has gone into a terminal phase. And so I often say that all hospice is palliative care, but hospice is the part of palliative care that comes in the final months or your final time of life, or when the treatments are not benefiting you or not wanted any further. And then it's time for hospice. And at a high level, hospice really is defined by an insurance benefit, by the Medicare benefit. And so that's another more technical definition on why there's a time period and that treatments have to be stopped. But palliative care is that concurrent care that can start at any time in a serious illness. It's best if it started at the beginning, but hospice is that kind of that final phase. It's the care that you can receive, the support that you can receive for your family. And then the focus is on providing comfort and dignity.
Let me dig into the hospice definition just a little bit more. How long typically is a hospice episode?
I'm not sure I know national numbers anymore, but technically it's defined as if the illness is going to have a course of 6 months or less if the disease follows the natural course. But that can be different for different patients. A lot of times patients are on hospice longer than 6 months. But I think the sad thing is we get patients in their final days and hours instead of their final months. And that's when the work is harder. And sometimes it's harder to achieve comfort and prepare families and prepare the patient, things like that. So I hope that kind of gives you an answer that you're looking for.
Yeah. So you'd mentioned that there are a lot of folks that don't come on to hospice until a little bit later than the hospice program was designed, since it's a 6-month window. So why do you think that there are families that are coming on much later than would be ideal?
There's probably multiple factors. I think that one, just prognostic awareness by physicians is pretty limited. Cancer treatments have become so different. Even since I've trained, the discoveries that we've had in the last 15 years honestly have made it challenging in that part of hospice where you have to stop a treatment to come on hospice. So for cancer, that's a little more challenging for physicians even to recommend hospice. And then also, I think that for patients, it's that hope in the next treatment that gets offered. And then for families, I often think families think hospice timing is too late. They probably could have used hospice services and the support much earlier in the course of the illness. But, for the patient to elect and decide, that's often when it gets, when the referral happens. And so I think one of the biggest things probably is still that the physician hasn't recommended hospice. And if they have, they've either been, reluctant to do it because they often offered hospice or something else. And then, the something else, the treatment gets picked.
That totally makes sense. And, I can see where that could make this kind of a gray area. So if you could wave a magic wand and you could say, I could set things up the way I think they would work better, what things would you change?
So if I could have the perfect hospice, I would say that the Medicare benefit needs to change to more modern medicine and stop requiring that people discontinue life prolonging therapy. And I think that it should be rewritten as a like a healthcare saving model instead of a fee for service model.
Right.
And I think that would definitely allow more people to come on earlier in a disease course. They may be outside a 6-month window, but if they would qualify in different ways, I would say the perfect world is we can take people at the time of diagnosis, and then there's kind of criteria factors that may come in later where the course of treatment may change to different priorities. But that in a perfect world, I would take away terminal phase or a time frame of 6 months, and I would also take away stopping life prolonging treatment, because sometimes it's not life prolonging. In some cancer patients, the immune therapy is actually keeping the cancer from spreading. So is it actually a therapy that's helping with comfort? Those are things that we're dealing with now. And so there are some people that don't qualify because they want to keep those treatments going. And I think if we took that away, it would be much better. I think we could be more of a cost sharing type of a program, honestly.
I totally agree. And let me frame that just so I make sure that I understand completely. You're saying that there are some patients that are receiving what would be considered life prolonging treatment for other reasons than life prolonging. They're actually helping them with managing pain, for instance, or helping avoid future pain. But it's not necessarily extending their life.
Right. It's a patient we had recently that had a metastatic melanoma, and it was involving the spine and the CNS, the central nervous system. And the immune therapy was described by the oncologist as, it's a fire hose on the fire. So it's suppressing some of the progression. And that patient had some things that they wanted to achieve. They had some goals. And so for them to stop that treatment, the cancer would have progressed, and they also would have had more problems with paralysis, possibly even other pain syndromes from having that involvement. And so in that case, they were going to be excluded. The other thing is that no hospice agency could afford that treatment.
Right.
It's not justified in the way we're paid to take care of that patient. It's just not enough. We don't have enough budget for medications. That would just completely eliminate probably a whole hospice agency, actually.
I think that leads us to the next questions that we have around the way hospice gets paid and what things they cover. So I think there's probably some gaps in understanding on what things hospice actually covers. And can you get into that just a little bit?
Hospice, everything around the care of the patient's terminal diagnosis, why they're on hospice, all of that is paid for through the hospice agency, and the hospice gets a daily kind of a payment to take care of that patient. And so part of that budget comes your physician, your nurse, your social worker, chaplain, your medical equipment, any supplies, and then medications that are related to that diagnosis. So not all patients stop all of their medicines coming onto hospice, but sometimes if a medication, let's say like a Parkinson's disease patient that's on hospice, some of their medications that are more on the extended release side, those are very expensive. And so you may change them to something that's less expensive, but they have to take it more frequently. So there's some nuances there. But like for any treatment, like a cancer treatment, or even some of our heart failure medications now that are very expensive, a lot of times that's not going to be able to be covered with hospice. But of course, a lot of those medicines, like the Parkinson's medicine, is for comfort. That's a part of their treatment plan. But like for a heart failure patient, it's not really treating their symptoms. It's a medicine that's in the guideline directed therapy. And so I think those are choices that are individualized by the hospice and the patient when they come on. I guess some hospices have therapists like music therapy or dietitian, things like that also get covered.
We also provide, physical therapy
Yeah.
to a degree, or occupational therapy, in order to help train families, or make some adjustments or modifications to the house, and that sort of thing, to kind of help once things progress and functional mobility declines, or that sort of thing. So in your experience, you've worked with a lot of patients and families. What are some of the myths or misunderstandings that you've run into?
Some of the biggest myths was, well, actually, I can even give you an example right now. We had a patient that the daughter said, you need to get off of palliative care because they're going to stop everything. And that's not true, because palliative care is concurrent care. It can start at the time of diagnosis, and no treatment plan really changes, except we're going to try to provide a layer of support and try to address symptoms. And, we may add medications to help your comfort, to help you be able to continue with your treatment. And then I think the misconception is that palliative care is hospice care, and it's not. Hospice care is that part that comes at the terminal phase of the illness. And then I think the other misconceptions on hospice is that they're just going to give you medications and you're just going to die. And there may be a misconception that hastens things, and it doesn't, because we just walk with the patient. And so we don't do anything to hasten death, and we don't do anything to prolong the dying process. We just kind of meet people where they are and try to help them die with dignity. And a lot of times that means helping them stay in their home, if that's the place that they want to be. And I think other misconceptions isn't covered if you don't have Medicare, but a lot of the private insurances do have some way to cover kind of a home care benefit. And so you can have hospice if you're not on Medicare. And I think those are probably the biggest myths.
When we're talking about overcoming some of these myths, a couple of things that we run into is that people think, well, that they have to be bedbound, or they can't leave their home, or they will significantly decline very quickly once they come on to hospice. What has been your experience with those things?
My experience is in a lot of cases, not every case, but in a lot of cases, people actually live longer with hospice care. So we do stop, in geriatrics, we do stop medicines and they start eating, or we do provide, multiple people in the home through the week, and they get socialization. They can find a sense of meaning and purpose. And so all of that continues to, I think, add add days, and hopefully, we're working on those being good quality days for the patient. And so I've seen the opposite. I see people that sometimes will start thriving, and we do have to actually think about that sometimes when we are providing medicines that they're actually taking them correctly because a nurse is teaching them and watching them do it. And so we give them those supports. So I that's been my experience most of all. And I did have a patient that was not going to sign on to hospice because she wanted to travel out of state. And that's another thing too, is that you can continue to live while you're on hospice. And so there's ways that we help people do that.
And can you dive into that just a little bit more?
Sure. So I had a patient that she and her husband had thought they wanted to go to Texas to visit some relatives, but I had recommended, and so had her oncologist in St. Louis had recommended hospice, and I did the referral, and then I got a message that they didn't want hospice, and I was like, well, that's not what we had decided. And so I called the patient and just let her know I was kind of surprised. She said, well, we want to go to Texas first to see relatives, and then we thought we would call, and I just let them know that you can do both. And so because of that, they went ahead and were able to sign on to hospice. So I was glad I made that phone call. I don't know that every doctor actually does, follow through like that. I just had a sense that this was, this just wasn't quite right. But
yeah, I think there's a misconception that there has to be some sort of major functional decline that has to be associated with qualifying with hospice. And it's surprising how many, if they come on early enough, because there's this focus by social work and chaplain and that sort of thing to say, these are your last days, and what do you want to do with these last days? And it's surprising. Some people have, lists of things that they want to try to accomplish. They sometimes are like, well, I really want to go to my granddaughter's wedding, or, there's a whole variety of things. And that hospice can try to align things for them to get to those final things. And some of those, are physically taxing things, or just like you said, with travel. One of the things that I want to kind of dig into, because we talked about myths that families often think, but when you're talking about qualifying someone for hospice, or even having the hospice discussion, there's the clinician side of things where, you've got maybe a general practitioner, or, even in several different layers, where there may be misconceptions about when to make that referral or have that hospice conversation. What, in your opinion, do you feel like that we're in the right spot, like we've done enough education, or is that area that we need to work on?
Yeah, I actually used to be on the Hospice Foundation for Outreach. Hospice Foundation at Ozarks just changed their name, so they had the ribbon cutting last Friday. But Hospice Foundation for Outreach, I'm now the chair of the advisory committee. So I actually asked that question. I sent out a survey. I didn't get very many responses, but one of the biggest things they wanted Hospice Foundation for Outreach to do was education still. So I do think there is a great need for that in our community, and also for physicians. I actually had a grant that I did some teaching in person at CoxHealth with our hospitalists. And I've also done, we bought them a palliative care primer and another book, The 4 C's of Palliative Care. And that's going to be given out to the nurse practitioners pretty soon at their next meeting. So we're constantly training and educating. And I just think that prognostic uncertainty still is kind of a hard thing to qualify patients for hospice if they don't have one unifying disease. So the disease-specific criteria are very helpful. And functional status, like the Palliative Performance Scale, helps if you have somebody that may not fit into one of those disease-specific criteria. And I think in our geriatric patients, like frailty, we can't put them on for failure to thrive. We can't use age-related disability, some of these diagnoses that we could use. Now we're using the most leading diagnosis. So like hypertensive heart and chronic kidney disease, if they're also with, heart failure and multiple hospitalizations, advancing illness from, other clinical things that we can find. And I think that's the challenge for physicians, because to try to paint that picture takes a lot of mental effort and a lot of actually recognition that the patient may be in their final months of life. And I think in patients, well, I guess in physician-patient relationships, if you have a very close relationship with a patient, you may not want to recommend hospice, because you don't want to lose your patient, because we have that also in our mind. So I do think the education need is there, especially for these diagnoses that just don't fit into the disease criteria. I think some primary care physicians really probably could use some help around that, just advancing illness and frailty. Also just, recognizing that patients with that functional decline, also, the unexplained weight loss and things like that also can paint the picture. But I think if I were not a hospice professional, I don't know that I recommend a patient for hospice if they don't have systolic heart failure, or if they have end-stage renal disease on dialysis, things like that. So I think that's the challenge too on the professional side.
So besides education, if you have a family that's starting to wonder if hospice is the right answer, and they go to a physician and the physician's like, no, I don't have the right diagnosis, or, maybe they're not quite getting the feedback that they were hoping to get on whether or not, because I think oftentimes families are like hoping that that's not the answer. They kind of have it in the back of their mind. They're hoping that physician's going to be proactive with trying to describe whether or not they really feel like it's the right timing. If they have other questions that they may not be able to ask their physician, or maybe they're not getting the answer they're looking for, where could they potentially go to try to get some of those answers?
So I think that's where I've just told patients they can self-refer to hospice. So they can actually call, and actually a nurse will likely, come out and make an assessment. And then, the hospice medical director or the hospice nurse can reach out to the physician for orders. So there is a way that kind of gets around that, need for an office visit. Because some people, if the family's asking this question, it's probably not easy to get the patient to the office to see the doctor.
Right.
So I do think that that's a way for people to also get access to hospice. So, and if they don't qualify, then the physician would probably be able to offer palliative care. So I always say, if not hospice eligible, or if they aren't hospice appropriate today, you can always use palliative care.
Starting those hospice conversations are really challenging, but it's like once you get the ball rolling, it feels like, at least even if they're not wanting to go down the palliative road, they at least have that information to know at what point they need to reach back out and do that. But self-advocacy, I think, is sometimes undersold in the healthcare system that we're in currently. And that's one of the reasons why we want to do this podcast, is we want to try to empower people to understand more on, if they're not getting the answers that they're hoping for or are needing, that there are other avenues that they can reach out to. I can just say, from a personal standpoint, my father was in the hospital, definitely needed hospice. Was very hopeful that they were going to talk hospice with him.
Mm-hmm.
They ended up not doing that. And even though I'm well aware of hospice and all of those sort of things, being the kid in the situation is just different. And it's hard to explain to people how challenging it is for a child of someone who's needing that kind of advocacy to step forward and say, Dad, you need hospice, when you're hoping that those medical professionals are going to help you make, because obviously you don't want to push that when it's not necessary. But in everything that I saw, my dad definitely needed to go on to hospice. And by the time, even in the hospital, they put him on palliative care, he was gone within 24 hours. And in the meantime, he suffered dearly in that period of time. So just saying firsthand, occasionally the system isn't quite where it needs to be. And, I was reluctant to pick up the phone and call a hospice agency and say, hey, my dad's in the hospital right now. Can you come visit him in the hospital? But that's something that you're mentioning you could do.
Yeah, and you can also ask the bedside nurse to contact the attending if you have hospice questions. That's a reason why we get consulted at the hospital in our palliative care team. It's one of our triggers in the ICU if there's questions about hospice. And so I think you also have your bedside nurse that can reach out to the physician. And I totally agree. You cannot practice medicine in your family. And so it does need to come from the other physicians. And I do think that you're right. It just doesn't come to mind to some of even the hospitalists. I don't know if it's because of the relationship that's a little different. They're overtaxed, and that they believe that conversation is going to be so in-depth and long, and they just can't do it with the amount of patients they have to see. So I don't know that it's always on their mind either.
I will mention that the difference that I noticed was that when they finally decided to put him on what they called palliative, and now this is a completely different hospital system than Cox, but when they put him on what they called palliative, it was really comfort measures more than anything.
Yeah.
There was no family support or communication or that sort of thing. And I can't tell you how important that would have been for me at that time, is having that kind of emotional support and understanding what was going to happen in the dying process, understanding what was normal or not normal, that sort of thing. Again, I'm well aware of what qualifies for hospice and that sort of thing. But when it's your own parent,
Sure.
witnessing that sort of natural state can be kind of scary. And so that's why I definitely feel you're right on the money on education is really, really the answer.
For sure. Yeah.
Let's talk about the pilot program with Cox and the palliative program. Can you tell me about how that's, I guess, different and what things that are kind of innovative that you guys are working on?
At Cox, there's a big focus on reducing readmissions. And so the palliative care team is one part of that. And so we have our pilot using some identifiers for people that might be at risk of a readmission for COPD and for sepsis. And then we've just added heart failure, just added at September 1st. And so now we're doing 3 conditions. So what's happened out of that is that we actually turned on an order. And so previous to that, if I wanted to call and get a palliative care consult as a physician, I'd have to pick up a phone and call and do a physician phone call for a consult. And so we got the approval to turn on an order. And so now a physician can just place an order and it sends us a message and we go and see the patient. And so for these patients, especially the sepsis one, what I was surprised is we're getting consulted earlier in the course of the illness. So we got a lot of patients on day 1 or day 2 when we used to get them on day 11. And then we're also getting kind of the unicorn of hospice palliative care. Because of sepsis, we're getting dialysis patients that we're consulting on, and it's surprising how many of those patients do not even have an advanced directive. And so that's the work that we're doing, is we're looking at, do they have an advanced directive? Do they have a code status? Do we have an alternative decision maker? But with COPD and sepsis, if palliative care was involved, that was one of the only things to help reduce readmission. The only other thing that helped was if they saw their primary care physician for a hospital follow-up within 7 days. You're right when you said your experience with your dad. It's you get not only the palliative care, you get the team. And so you get my social worker, you get our chaplains. And so we're kind of looking at you at the whole person. We're not just looking at the heart or your lungs. We're looking at you as a person. And I think that's been very helpful. And also just making it easy for the referring physician to get us involved. I know that doctors need to talk to doctors, but it was easy for them to place an order instead of having to do a traditional consult, physician to physician phone call. And so our numbers have really gone up. We used to have about 80 average a month, and now we're at like 296.
And when you say referrals, you're saying within the Cox system, for the most part, at this point, is easy. Right. What about physicians that are outside of the Cox system that might want to refer to this?
So this pilot is inpatient only.
Okay.
So other physicians in the community, especially like post-acute care, at the skilled level, they can also do a referral to palliative care. And there are some programs in the community. I think it takes your case manager to send an order, and then they come and evaluate the patient. So there are some referral pathways there too.
That's amazing. So how long has this pilot been going on, and how long do you think it will continue?
So we've been working on it, I think, since January. The order was turned on mid-February.
Do you know how long the pilot's going to last?
I'm sure it's going to be a year. And then I think they're going to probably crunch the metrics on it. So we're kind of coming into our final quarter, I think.
Do you have, I guess, hopes that you can influence our healthcare system as a whole with this pilot?
I would say proving our value has been beneficial with this because we're involved earlier. And so I remember one of the patients that was admitted to the ICU was sepsis, but she actually was undergoing her first cycle of chemotherapy for uterine cancer, advanced uterine cancer. And she had severe diarrhea with her treatment. And so during that, she became dehydrated, she fell, and she broke her ankle. And when she presented, she, of course, had sepsis from UTI. And so she was in the ICU, and she was upset because they couldn't do surgery to repair her ankle because of the infection. And then she was kind of a little bit of a woe is me type person, like, I've got cancer, and now I've got a broken ankle, and now I've got, I can't have surgery yet because I have to get over the infection. And then through that, we were consulted on day 2. And so we discovered that she did not have an advance directive. Of course, you can sense the emotional state that she was in. And so we were able to have our social worker start working with her to process her emotions, got reconnected with a sister that was out of state, got her advance directive completed. And we got all that work done during this 11-day hospital stay. And previously we would have been probably called in on day 10 to 11 of that stay. But through that, we were able to work with her. And it took that time to be able to help her process things and to be able to help her make plans and commit and things like that. And I really felt that really should prove the value to a hospitalist or to another physician, because we're doing important work. And often when we're involved at the right before they discharge, we don't have the time to do those things. And so if we get involved earlier, I think the value is going to be shown just because of that. And the support for the physician, so they don't have to carry that on their shoulders. So
one of the challenges with a true palliative program is that at this point, there's not, outside of the inpatient hospital system, there's not a great payment model for independent hospices to have a true palliative program. Oftentimes the billing has to go through a physician fee schedule, and there's just a lot of things. And so, there's a lot of palliative type processes that a hospice will do, but they don't have a true full, palliative program because there's just not a payment model for it. And that's one of the challenges, I think, that really needs to be addressed within the healthcare system, I think.
I agree. Yeah. You're only going under physician or provider billing. And so that definitely will not support your team. So it's a very sometimes hard conversation with places, because they see, money in, money out, not necessarily savings, which should kind of show the purpose behind it. But I think through the readmission work that we're doing, I hope that our system that we work in, and I'm so grateful for CoxHealth supporting us now, but I think they'll continue to support, maybe help us grow as we show them that we can help in different ways. So instead of necessarily I guess we're just another aspect of the care for the patient first, right? And then we're also helping the system out because they're not getting hit with some other quality things that happen if a patient gets readmitted and they don't get reimbursed for the care and things like that in 30 days. So
Yeah, I think there's a lot of cost savings that are related to palliative care and benefits to the patient and families that could be brought in sooner. And we talked about this earlier, but the time that it takes for someone, because there's life-saving treatment that happens sometimes to the very, very end, and you put someone on hospice in a very short period of time, all of a sudden you've kicked in this entire hospice team that needs to get with this family and the patient and prepare them for something that's rapidly approaching. Ideally, you want a certain period of time to get with that family and prepare them and that sort of thing. Do you have kind of an idea of how long would be ideal to be able to do the family component of hospice for someone?
I really feel like it takes about a month to 3 months, depending on the situation. And so that's where I do think it is different family to family. And, just the differences in how much preparation they already had before they came onto hospice. I guess I've always kind of compared it when I've talked to students about, finding out you're pregnant when you're delivering the baby in the ER, that's messy.
Yeah.
You're not prepared. There's no plan. And that's sometimes the way we approach dying is that, we aren't prepared. And usually you get 9 months to prepare for a birth. If you're lucky, sometimes a little less, but you do have that time to kind of get the sense around and get everything in ready and in place. So I think it does take probably months to get ready for that.
I kind of feel like I don't know how long time it takes to go through, the mourning process, because a lot of hospices know that mourning process happens well before the person passes away. That family has to wrap their emotions around that situation, and it takes time. Otherwise, damage could be done. In my opinion, it did for me, and mitigating that damage would be very helpful if people start having some of these conversations earlier. And one of the things that we're really zeroing in on in this podcast is trying to help people with some of the complexity of these different issues so that they can start making a plan in a lot of different areas, even legal. You'd mentioned, having, some of these folks don't even have a DNR in place or a lot of, a will or, advanced directive, that sort of thing. And so we've had people on the podcast that really, that's what they do. They do it day in and day out, and really trying to prepare people with all the things, because once people start preparing, that little bit of planning is part of the emotional process. And in my personal opinion, and there's probably data out there somewhere on this, but I do think there's value in that. Folks you've walked people through this whole process, and you've probably seen the very short term and the longer term on both sides. How did those feel different when you're just looking at the family dynamics itself?
I guess I would answer it this way. Sometimes they just can't make the decision. Kind of the thought that came to mind was just walking into the ICU one morning when my patient had a sudden decline in status, and we found out that she'd had a bleed in her brain while she was in the hospital for pneumonia. And so when I was walking into the neurotrauma ICU, the nurse was at the door saying this is not a life-sustaining rhythm, and they were going to have to start CPR again if she lost her pulse, and asking the family on what they would do. And her daughter was at the bedside, and her husband was very emotional. And her daughter just looked at me, and I could tell with the look in her eyes was just like, please just don't, please stop. And so I had to make the decision. I said, no, we're stopping. We're going to change the focus to comfort care. And of course she was definitely in a dying phase. And so, I've seen that. And then I've also seen the other aspect of where, the family is totally ready for hospice and the patient is not. And the family is at the bedside. I remember another patient that the family, I think the patient finally went on to comfort care, and the family was they were in the chair next to the bed. And they were like, well, what's going to happen when his heart stops? He was adamant that he wanted CPR. And I said, that's not part of our comfort care plan. We are going to allow him to have a peaceful death. And they just were like, so relieved that I even said that, because they were afraid that he finally got comfortable. And then now we're going to just, cause all this discomfort and commotion, and it wouldn't be, what they were hoping for. So I've seen those kind of aspects. And
Yeah.
then I've seen those that have been totally prepared. Like they've got everything written out. My husband's going to be that way. He's going to write his own probably paper funeral arrangements. Everything's going to be written down. And, I know he's going to have the honor guard there, everything. So, I mean, it's just going to be all in detail. And I guess I would just say, we die as we live. And so it's very different for different people and different families.
That's so true. And I love that you mentioned how the plan really makes a difference for the families. Because I think sometimes we get so focused on the patient themselves and what they want, and as we should, but we've got to factor in those families and say, what can we do to try to make things a little bit easier? Because we see it a lot. These families have to make a lot of decisions very quickly, and they're in mourning. They're trying to deal with the loss of this individual, and some might argue that, well, they're being kept busy is a good thing, but I would argue that, I think the better way is to be prepared for these things ahead of time.
Yeah, I agree. I do agree.
Let's shift gears to the soft surrender.
Sure.
So a new hospice movie is being premiered November 1st here in Springfield. So tell me about where this movie came from and how you became a part of it, and what role you play in it.
Probably a year and a half ago, maybe a little longer, as president of HFO at that time, Hospice Foundation for Outreach. I was the president of the board. We had the opportunity to be the executive sponsor of the film. And so Randy Bacon is a local photographer, film expert. And he did this 15 years ago in a different documentary. And so he was going to update the documentary. And so we were becoming the executive producers for that. He's finished it. The trailer is out. It's beautiful. I mean, I can't tell you, I've seen the trailer several times, and every time it's going to be a heartwarming group of stories. And so we had asked him to, look for I think 6 patients, and we tried to match them with clinicians. So like a physician, nurse. And then there's also a photo exhibition that's going to be with it. And so the world premiere, the first showing is going to be November 1st, and then it goes on to the film festivals and things like that. So we are super excited. I've not really ever been a part of a project this big and this community focused, part of education. And I'm just really excited. Hopefully we can present the photo exhibition and get it on tour also, because that's going to be pictures, but it also links to the story. And I think when I've always listened to like hospice and how to market hospice, they want stories. And that's a very powerful thing. And so, I mean, this is probably the most exciting part of medicine right now, is kind of getting back to a little bit of the humanities and doing it this way. And so there are plans to make a curriculum along with it using Missouri State University faculty. And so hospices could even use it as a curriculum to train their staff. So yeah, we are super excited, if you can't tell.
So I feel the excitement. I'm excited too. So what story does the film tell about hospice, and why is it important for the public to see?
So again, he hits your heart. So I think it's going to showcase how to live in the setting of a terminal illness. And I know I was involved with my patient. She and her husband are my patients, and they were the ones that didn't think they could travel on hospice, but we went to their home. He was taking pictures of her, and she's just a beautiful lady. And it was a really kind of emotional visit to hear their story as a relationship, and him, she wanted hospice for him because she knew that he wasn't going to be able to handle it as well. And so, and she's been on hospice now for about 8 months, and so she's going to get to watch the movie in a couple of weeks. So I'm very excited for that. For the earlier showing. And I think it's telling the stories. Also, we have an ALS patient, to show how hospice helps in those situations. So I think it's going to be really great.
So you mentioned using this kind of as a curriculum for clinicians. What's the number one takeaway, or hoping they take away from this movie?
How do we help people live in the setting of a terminal illness? And hospice is a way to help you live comfortably, hopefully in your home. We try to help you have enough support to be there. And so I think that's probably the biggest message is, what does hospice look like? What does it help with? And it basically helps to support your dignity and your comfort, and helps you live in your final months of life.
You've been working in hospice for a long time. You've seen it most of your life, or had some exposure to it most of your life. It is a very emotional, tied part of healthcare. People think of, science and, logic, but it's very difficult to untie the emotional aspects of this. How do physicians or any clinician try to deal with the emotional side of it? I know our clinicians in our hospice are just a special type of person. They just are kind of built like that. But what things do you want a physician who's kind of considering going down this path, they need to know ahead of time so they can be successful and deal with the emotional side of this?
One of the things we talk about is resiliency. And I don't think resiliency means that you're unshakable or unbreakable. I think that just means finding ways to, I guess, work with this challenge and loss. So, I have things that I do to help regulate my emotions, and that's, watching funny movies, enjoying time with my family, exercising. And so I can tell you that just in this work also, I think if you have your mindset or your goal of learning about the person and helping them be comfortable, then even though death is a painful, emotional thing, if your role in it is to make it as peaceful and comfortable as possible, and you've met the patient where they were and honored their wishes or preferences, then that's work well done, right? And so I do think that's also part of it. And I think that it's an invitation. Families invite us into their home, and that's also and something I don't take lightly. That is something that also it's an honor to do that, and an honor to care for people in that way. And I think also for some of the other staff members, I think because we're a team, if I've had kind of a rough day, like when my next cousin, my closest living cousin in age, he had a motorcycle accident, and the day they were going to take him to donate organs, I walked into the hospice unit in Wichita, and there was a patient that had a closed head injury from a motorcycle accident, and he just was same age. And, I became emotional. And so I had the chaplain, right? So I got to go sit down with the chaplain and just take a breath. I didn't realize I should have taken the day off, honestly, because, and doctors were told patient care first,
Right.
and that kind of thing. But I think that that's something to remind a clinician if they're thinking about doing this, is that, you are going to be able to rely on your teammates, and not just patient focused, but also, we help each other on that too. And so those are some of the takeaways I've had through the years. And I also can tell you that balance is another part of it. And so I have to have a balance. So I do my palliative care work in kind of a leadership role, some consultations, but I have my primary care role as a geriatrician. So I still get to talk about preventive care and help people to get better. And if I don't have that balance, if I'm too much, on the hospice palliative side, then to me, that's harder. And so that's where I think for physicians, if you're going to be like a hospice medical director, you can kind of have it, some do great having it their whole practice, but you don't have to do that. You can have it as kind of a side role.
Your answer really actually made me think a lot about this. And I don't know that we've really discussed it on this podcast at all, but, clinician support, and, burnout's rampant in healthcare right now. And I think so much of it is a lack of support within the healthcare community as a whole. I know I felt this when I came out of school, that, you're just, it's your job, go do your job. And that mentality can be counterproductive for someone who's, because what I see as burnout sometimes is this emotional shutdown. And that connection with those patients is absolutely vital. And you want to see clinicians that are still very much engaged and still very much care about their patients. And if they have to put up these walls to protect themselves emotionally, it interferes with their ability to do a great work. But I don't know that the industry as a whole does a great job of offering support to physicians, who are supposed to be, imperfect, and some of those clinicians, because, it's like we're not supposed to feel,
Yeah.
we're supposed to be, super people or whatever. And I noticed that in the industry that has affected it in a not so great way sometimes.
It's talked about more, which I appreciate. It wasn't talked about when I trained. And so I think a lot of that compassion fatigue, if you can actually have some insight to where you can kind of know that you're just like, I don't know how to say it, just either not listening, not paying it, not in the moment, if you're just glazed over or just, going through the motion kind of thing at work, that's where hopefully you have some support, at least enough to say, hey, I got to take a vacation, or I got to take a day off. And usually that's probably the easiest way to kind of get some recharge in the moment. You probably need to talk to your team members and say, hey, I think it's a bad day for me. You're gonna have to watch my back. I tell my nurse that all the time, like, have my back, if I make a mistake. And that's where probably the biggest thing, I'm so thankful in my practice that I've been able to practice team-based care my whole career. And so that's where, if they had a bad day, I can step up and that kind of thing. So, but yeah, the compassion fatigue, that's out there and real. And I think it is harder right now, even because of the other system-based pressures and things that we have, doing more with less resources, less staff and things like that. And then another thing I think in hospice, and you can cut this out of the podcast if you want to, but hospice is not the same as it was 20 years ago. So when I started in the hospice GIP unit, we didn't discharge patients. We didn't have that pressure. Now you have to discharge people, and or even discharge live discharges, and they're tracking that. And I do miss sometimes that aspect of, where hospice really didn't have as much regulation. And so I think we were able to do the mission and the purpose without that kind of over your shoulder or over your head or on your mind.
Well, we see those changes also on the home health side, and most of those changes on the home health side, unfortunately, are related to Medicare Advantage. Pretty much I think it's over 50% now. There aren't as many people on traditional Medicare, and that has changed the landscape significantly. They are talking that Medicare Advantage is going to start to move into the hospice space. They're really pushing that a lot. When that comes, it sounds like it's going to come. What do you foresee might impact it at hospice as an industry?
I'm just going to tell you, if I have to do a peer-to-peer to qualify a hospice patient, I'm not going to do it. As a primary care doctor, I'm sorry. And
Yeah.
that's awful to say and selfish to say that my time is not worth getting a patient a service that they could qualify for, but to have to prove it and have to go through some sort of a prior authorization or a peer-to-peer to do that, I'm sorry, that's going to be terrible. And actually it just hurts the patient, which is even more terrible. But that's the biggest thing I see with the Advantage plans. If I'm doing anything, I have to do extra. And it's like, did they even read my note? I mean, was it AI in 10 seconds that said I didn't say one word right? I don't know, but I am not happy about that.
Yeah.
If you can't tell.
Yeah, and you're not alone. We hear it constantly all over. It's I don't know that the general public maybe hears it quite as much
I don't
as
think so.
we. And administrative burden is something that it's not against the law for an insurance who probably could claim that they're trying to reduce cost, but that administrative burden unfortunately is affecting care, and their effect on care is kind of where I'm digging in just a little bit more. If we see outcomes at a certain level, and that a Medicare Advantage takes over in hospice, what do you think will happen to the patients that need it?
I think they're not going to get hospice. I mean, if you have a patient that you're referring for GIP in the middle of the night and I have to do an extra step to get it, I'm sorry. I
Yeah.
don't know what it'll look like, but it's just going to be more barriers. And then that's just going to stop referrals. Because if a doctor is told that, they don't qualify or something, or the insurance doesn't think it's necessary for hospice, they're just going to stop referring. And that's outside of even an Advantage plan. They might have a traditional Medicare, but they don't differentiate because they don't have that knowledge. But I'm just saying, so traditional Medicare has to follow the traditional Medicare law, but the Advantage plan, since it's a replacement, they don't have to follow the law, and they're kind of getting in trouble for that. And so I don't know exactly how that'll impact them coming into this space, because I think they get reverted back to their traditional Medicare A.
They do.
I don't know what it's going to look like, but my experience in dealing with it right now for just chronic care management of my patients, it's not a good thing. I made my parents swear they would not get an Advantage plan. So that's how much I think of them.
So, well, thank you for sharing that honesty. So, if you were to provide a message to regulators or policymakers, what would that message be? How would you, I guess, if you wanted them to regulate something, what would that be?
I mean, regulate the work that we want to do, like the amount of comfort, patient satisfaction, caregiver satisfaction, bereavement support. I think just measure what we actually do, show the work that we're doing, and don't make it a competition between hospice agencies. That kind of thing, I think, would be ideal.
I think agencies in general need to really come together and work together to make sure that we're a united front and protect the patients that need the care at this point. I couldn't agree more. And I really appreciate you mentioning, it's one thing I failed to mention earlier, was that if someone's on a Medicare Advantage plan and they go to hospice, they revert to traditional Medicare as their payer. And so that has simplified things for the industry. And I know the insurance companies are really lobbying heavily to get into this space. They don't want people coming off off Medicare Advantage and going on to traditional Medicare. And so it's definitely an area that we're looking at. I know that there's some areas of the country this has already happened. I just don't know if they're advertising the outcomes and the changes from the providers. Those providers may not be as vocal as they need to be about what they're seeing in those spaces.
I know it's being talked about. I've been in some hospice homerooms at our national meeting, and it is discussed, but we don't know enough to know how to address that.
There's a whole lot of things, and we don't have time to get into all of the areas in which we've seen, but administrative burden is really just one of those things that I think we've got to address. Okay, so let me just shift gear to something a little more fun. You have a hobby where you give gifts to your grandkids every year. You want to talk about that a little bit?
Yeah, I guess. Sure. So I have 3 grandchildren. And so each of them gets a scrapbook every year. So I make basically a photo album of their year. So it used to kind of start with their birthday, but now it's just kind of the year because they're getting more active and doing things like with sports and school and things like that. So that's kind of my hobby, my gift. And I guess probably my work in doing this is storytelling and memory capturing. And so it kind of fits into that too. But yeah, they each get a scrapbook. So
that's the beautiful thing about working in hospice. Yeah. You learn to those memories mean everything, and making every day count and all of those things. So I love that. Well, I can't sign us off without circling back to the movie premiere.
If you are interested, you can contact HFO either online or by phone. And then at the Gilloy on the website, you can actually purchase tickets. So there's 2 ticket options. There's a pre-party, and then there's also the general admission. And there are sponsorships options available where you can get the whole after party, everything like that. If people are interested, just contact Anjanette or Matt with HFO. And I hope everybody can come and enjoy it. I think it's going to be beautiful. I can't wait to see it. We get a little preview in a couple of weeks. So
I'm so excited to see this. Yeah. I know we're going to buy tickets here. We're going to put all the information in the show notes and make sure that we've got everything up for everyone. And we are going to just promote this. I think it's such a wonderful idea. And I just want to thank you for just the work you do, all the things you do with Cox and the palliative program, being a part of that, soft surrender movie. And I'm just really excited to see it. And I'm very grateful that you came on the show and shared your vast knowledge. We would love to, as things change in the hospice area and new things come about, we'd love to have you back on.
I would appreciate that. So yeah, thank you for the opportunity.
Dr. Gaines, thank you so much. Absolutely. I will see you there.
All right. Thank you very much.
Thank you. Wow, Dr. Gaines, she has got her hand in so many things. And the thing that's probably one of the most exciting things is this movie that she's promoting right now, that she's been a part of with the Hospice Foundation for Outreach.
That's right. Soft Surrender. It's going to be playing at the Galois Theater on November the 1st. Tickets are on sale now at galoistheater.com. They're even going to have an after party. So it sounds like a lot of fun.
And it's all about educating people about hospice and trying to help people understand all the myths around it. And, I really think healthcare providers could benefit from this movie just as much as, even as a provider, I thought I understood hospice, but over the years since we've been working in it, it's just amazing. It's just so much more than people that really, really understand. The other thing that impressed me about Dr. Gaines is that, they're piloting this palliative care program at CoxHealth. And, it's really cool that CoxHealth is, trying new innovative ways to try to provide care. And they couldn't have a better person in charge of that. And it's really impressive.
Absolutely.
If you enjoyed today's conversation, make sure to like and subscribe so you never miss an episode.
And we'd love to stay connected. Follow us on YouTube, Facebook, and on Instagram at In Good Company Eldercare Podcast.
You can also find us on X, formerly known as Twitter, at IGC Pod, and on TikTok at IGC Eldercare Podcast.
Thanks for tuning in to In Good Company Eldercare in Your Backyard. I'm John Ray, and I've been joined by my amazing co-host, Spencer Ernst. Special thanks to our executive producer, Alex Wallace, for helping bring this show to life. Until next time, take care, and remember, you are always in good company.